so thank you so much. I'm based at University of Sheffield in Doncaster and Bassetlaw Teaching Hospitals and work here as Professor of Nursing and Gender-Based Violence. I also lead FIMO Research Committee, and this webinar and these meetings we organize every 3 months or so to be able to talk about different research topics. We are trying something different, that instead of just talking about research within the committee or just administering award or something like that, if we could contribute by sharing knowledge, and at the back of that, it would allow us to provide mentorship opportunities, discussion opportunities for different individuals to increase awareness of research and different research topics which are relevant, and also to then allow people to be able to know who to contact when, so to speak. So I'm very grateful to Professor Sue Letta for doing this session for us today. This is the second one of the series. Professor Letta is based at School of Health Sciences, University of Southampton. She leads the Medicine Management Research Group in the school. And her research focuses on medicine management by a range of healthcare professionals working in different care contexts, which includes supporting medicine management for people at home, in later years of life, antimicrobial stewardship, understanding and promoting safe and effective prescribing of antimicrobials in hospital, primary and community and out-of-hours settings, and de-prescribing high-risk patient groups. So thank you so much for joining us and for doing this session for us. And you will be talking about using case study design in health research. So over to you.
Thank you, Parveen, and hello, everybody, and thanks for that introduction. It's my pleasure today to talk on behalf of the FIMO Research Committee, which I'm a member, to talk about case study research. So case study research is something I feel quite passionate about. It's something I've used in my own PhD. It's something I've used in funded research projects. It's a feature of some of my PhD students' ongoing work. So I'm going to try and draw on some of those examples today as we go through the slides. And I'm thinking that some of you might be thinking about using case study design maybe in your own PhD or your own projects as an early career researcher, or you might be thinking about when you're reading case study design, how do you evaluate what's a good case study or not. So I'm hoping you can take what you will from the session. So my slides are not moving down. Let's try that one. Okay. So what I'm hoping to cover today in the hour, and also to leave some time for questions and discussion, is to just look at some of the defining features of case study research, then think a little bit about what questions or when we might want to use case study design for what type of research questions. Then moving on to the practicalities of when you're designing case studies, what are the sorts of practical things you need to think about, settings, how you sample both case sites and within case studies, thinking about how you manage data collection and analysis within a case study design, tricky issue of writing up, and then just to finish with looking at some of the issues or challenges with case study research. So just thinking about defining case studies first of all, and I think this starts to give us a feel for how they sit in relation to other designs that you might choose to investigate your research questions. So John Cresswell describes case study as an exploration of a bounded system, and we're going to come back to boundaries of a case. It's something that definitely takes place. It's a design where you will need to spend time in a case site. It is about detail, it's about in-depth data collection. It does usually involve multiple sources of information or data. We think about triangulation there, and building up a sort of content-rich database. So that starts to prick our ears about some of the key features of case study. And Robert Yin, who's some of you who might be familiar with case study, he's one of the key writers in case study design, adds to our thinking by saying it is definitely about studying something, a phenomenon, be that an intervention or something, whatever you're interested in its real life context. So there's no attempt to try and manipulate anything or to extract the thing you're interested in out of context, but it's in its real life context. And also sometimes, we're all hopefully on the line, we're healthcare professionals. when the thing that you're studying and the boundaries between it and the context are not entirely clear. So if I gave you the example of, we recently finished a study for the National Institute for Health Research, where we were looking at access to medicines at the end of life in the community. And what we did was we took case studies of different service delivery models. So we looked at a general practice delivered end-of-life care. We looked at a site where there were nurse prescribers delivering end-of-life care. We looked at community pharmacy and how medicines access was working from community pharmacy. And we looked at specialist palliative care 24-hour service. So we weren't sure within each service context where the boundaries were between the delivery of medicines and how that sat within the context. I'll come back to that to try and illustrate that more. Just thinking a little bit more about how case studies are defined. So it is a bounded system. You have to put some boundaries around what is your case. Robert Stake is the other person more on the qualitative end of case studies that's written quite a lot about this. And you have to, when you're designing your research, think about where those boundaries are going to land. Bounded by both time, how long are you going to be in the case, when does the phenomenon start and stop, or how long, because of your resources, are you simply going to be in the case? And also thinking about, what's your case going to be? Is it going to be bounded by, is it more appropriate to study something at a ward level, at a hospital level, at a trust level? So what are the boundaries of your case is an important thing to think about. And describing and analysing the real life context is important to the thing that you're interested in. I was thinking about this morning. I thought, well, actually, if you were doing, let's say, some qualitative interviews, you weren't choosing case study design, you were just going to do a qualitative interview study, you would still pick up information about context, probably through talking to people and understanding perceptions of context, but it wouldn't be the same depth or breadth of understanding context as if you used a case study design. So you're really interested in context and how something is working in context, case study is a good choice. It does take time, so it's something, thinking about, you know, whether you're doing a PhD part-time, it's quite tricky to do case study design because you need to spend time in the setting, really gathering data about the context. And it can be quite intense because you have to use multiple methods and really immerse yourself in the context sufficiently that you get that rich data to provide explanation and theory building. Just thinking a little bit more about the context. I keep talking about it. You'll have your own ideas about what context means in healthcare research, but it might relate to things like the values in that setting, or the leadership style, or the way care is organised, or hierarchies, or what kind of authorities or power relationships are in operation. Lots of things go to make up context, and each phenomena that you're interested in will have a unique sort of contextual features that you're interested in. But often context is important in explaining what's happening at a particular nexus of location or people. This is Walker speaking now. What we often find is that the things that are important are the things that relate to context. They're the things that influence whether an implementation of a new intervention works in practice. We all know this, I think, from our own work as healthcare professionals, that context is incredibly important to the way new interventions land, or how people experience care, for example. And Walker also says it's the circumstances, and there's also this thing about history surrounding events that is most relevant in explaining them. So, for example, I've got a PhD student at the moment, he's a paramedic, and he's looking at how paramedic prescribing has been implemented in emergency and urgent care settings. And he has two case studies. So one is an A&E ED department, and he's using multiple methods to understand. He's used observation, he's used informal interviews with the paramedics that he's been observing. He's interviewed other healthcare professionals. He's looked at documents in the site, and he's looked at prescribing records of what's being prescribed over a period of time to actually try and understand how does that context of A&E actually influence how paramedics are working and prescribing. And then he's also taken an urgent care centre, used the same methods, but to try and capture the context of that urgent care centre, and how that is influencing the implementation of paramedic independent prescribing. So just moving on then, context again. Context is important because, and this is a slightly different point, context is important because it also, thinking about external validity now, or generalizability or transferability, understanding context is important in determining how far your study findings will be applicable beyond the sites that you've actually been in. I'll come back to that later. Also, context is important because we know as healthcare professionals that values are often embedded in a context and can determine the thing that you're interested in, the study findings. So you've got to try and eke out of the context what values are here that are influencing, shaping the thing that I'm interested in. So, for example, if we go back to the example of paramedic prescribing, something that's in the prescribing literature that we know about is that there are prescribing hierarchies often in operation particularly in hospital settings. So if someone prescribes something, another medic might not be inclined to, or another healthcare professional might not be inclined to change that prescription because someone else has prescribed it and they don't want to upset the hierarchy. So that's a kind of an embedded value that maybe needs to be drawn out of case study work when you're looking at, for example, paramedic independent prescribing. And there's this thing about context, and the thing that you're interested in will be shaped by each other, really. This is case study is not a design where you're thinking about a linear causation, that if you do X, Y will happen and then Z will result. It's much more complex than that. And that's why case study more recently has often been linked to investigating complex interventions, which might be on my next slide. So just to make it a plea for why case study research is important, a couple of people have been writing about this fairly recently. When we think about the frequency with which innovations are implemented in healthcare settings, and how well the case study approach lends itself to this kind of in-depth, complex health service research, there's people calling now for the approach should be more widely considered by researchers. Although it is challenging, case study research, it can, if carefully conceptualised and thoughtfully undertaken and reported, yield powerful insights into the many important aspects of health and healthcare delivery. I think my next slide is about it's a good paper, and it's on the reference list at the end by a team that have actually developed some reporting guidelines for case study research. But they've thought about case study research in relation to complex interventions, which probably most of you will have read about, if not been involved in research on complex interventions. So contemporary healthcare systems require complex interventions. We know that, be it the introduction of paramedic independent prescribing or electronic prescribing in hospital settings, and success is usually partly dependent on the relationship between the context and the intervention that is dropped in, new intervention. And going back to this point about external validity, so we need to provide evidence about the context of interventions because it is important about thinking about external validity. So people who are going to use our research, policymakers, commissioners, other users, they need credible evidence of the relevance of the findings to their own settings so that they can, what Shaw et al. Call, perform careful abstraction, so they can take your findings, if you've described the context, if you captured it properly, and apply it to the settings that they're interested in, or the patients or the population groups that matter to them. So it is really important. If you've got nothing about context, you don't really know whether would this apply to my urgent care settings or my A&E. So context is so important. So they conclude, it's a good paper, I'd encourage you to read it. Case study research is an important methodology for studying complexity and an invaluable resource for understanding the influence of real-world context on complex system-level interventions. So, as I say, I've had a couple of funded studies which have looked at complex interventions through a case study design, or actually case studies have formed part of a bigger study. So my study that I just referred to on access to medicines at end of life, what we started off with was actually a big online survey, questionnaire survey of healthcare professionals, asking them about their experience of providing access to medicines in the last 12 months of life. Then we did our we did 4 case studies of practice that I referred to earlier. And then we wrapped that up with a sort of co-production workshop at the end where we presented our findings and asked people to generate recommendations and implications with us. So case studies can be part of a bigger design too. Where does case study come from? Not necessarily from health service research, but from psychology, from law, political science. And we know that medicine have a tradition of case study, clinical case study, which is something we might want to just come back to at the end. But there's a tradition in medicine, isn't there, of the grand round or reporting a particular clinical case in all its complexity, and people generalizing from that clinical case to think about how what lessons might be learned from that. There's a similar principle underlying case study research, although it is not the same. So I think hopefully increasingly more recently, people have been prepared to take on case study research in healthcare too. Thinking about where do we sit on this kind of epistemological scale. So there's been some debate in the literature about where case study sits. So Robert Yin very much takes a positivist approach to this, that you start off with a theory and you choose your case studies and you sample within your case study sites to test that theory, to test out the propositions and to refine or refute the theory. On the other hand, Robert Stake is very much about induction and theory generation from rich case study data. The Crow et al. Paper, that should be 2013, I think, say it depends. You can take a critical stance or an interpretive or a positive stance or a combination of those. I'm just going to elaborate on that just a little bit. So, taking a critical approach to case study research where you're very much questioning your own assumptions, but you're taking into consideration, I think this is really important, often in lots of healthcare research questions, taking into account the wider political and social environment. So you are collecting data at a case study level, be that a ward, a GP practice, team of community nurses, but you're also allowing yourself to think about the wider political and social environment that shapes the way that care is delivered. So, in the final write-up of the case study, you might be interpreting the limiting conditions in relation to, for example, power and control that are thought to influence behaviour. So, that might be about the resources in or hierarchies or within the setting that might shape what you're seeing at ground level. And then, as we all know, you could take an interpretive approach. So you're understanding meaning and context and processes as perceived by different perspectives, trying to understand those individual and shared meanings. So from bottom up, your theory building, or you could take a more positivist approach, and it's in advance thinking about what variables you want to study, what theory is there that you think explains the phenomenon of interest, and actually deliberately sampling both your case sites and within your case study to actually test out those theoretical propositions. So the focus there might often be on testing and refining theory. And I was thinking when I was preparing this really that, there's some alignment here with, theories of implementation science. And if you, for example, thought about normalization process theory, I don't know whether any of you are familiar with that, but you might think, okay, I want to understand how electronic prescribing has been implemented in A&E settings, let's say, and you might think, okay, I'm going to take normalization process as my theoretical framework. It's been shown to be quite reliable at predicting whether something's implemented well. So you might take the concepts in normalization process theory and actually, do your data collection and sampling to actually test out whether things like whether the concepts in NPT are actually shaping the implementation of electronic prescribing. Hoping I'm making sense. Okay, so what sort of research questions might be really suitable for case study design? When context is likely to be very important in explaining the thing you're interested in. As I say, it's not the only design where you can pick up information about context, but it's likely to be a really powerful one for generating a lot of information about context. And Ian also talks about it's very useful for understanding how and why type questions. So it will give you, if you get rich enough data, explanation about why things are happening. So just thinking a bit more practically about how you get on with designing a case study. If you're at the beginning of your PhD or beginning to think about designing a proposal for funding. So obviously you've got your question in mind, and you have to make a kind of a well-informed, on the basis of our clinical experience or what else is in the literature. You've got to decide on what each case is, or case study researchers often call them units of analysis. So I've talked about, in the examples I've given you, my PhD student is an A&E department, an urgent treatment centre. We used a GP practice, a team of nurse prescribers working in a area of one trust, and then we used a 24/7 specialist helpline, because that made sense to us. It was a kind of a service delivery model that we wanted to see how those different service delivery models influenced access to medicines in the last year of life. But other case study researchers have used people, single patients over time, and let's say the healthcare professionals that interact with them over time. Let's take the example of access to medicines at end of life again. I might have chosen to look at individuals and their carers over time and who they get to interact with, so they form the case. Sometimes there's no right or wrong answer. What we were particularly interested in the example I'm talking about is service delivery models, and actually how they influence experiences of access. I suppose I'd say, in setting the boundaries of your case and thinking about the unit of analysis, if you set those boundaries too wide, it's going to be I think it's difficult to actually collect the richness of information that you need in order to do justice to understanding the context. So people do use whole trusts as case studies, but you need to think about how thick or thin your data is going to be if you're working right across the trust. And I think we all know as healthcare professionals that actually sometimes context varies, doesn't it, within a trust. I mean, I remember when I was newly qualified as a nurse and deciding which ward I wanted to work in at the teaching hospital which I just finished training at, and we all knew that the culture or the context of different wards was very different. There were some wards we all liked because there was a good ward charge nurse or ward sister. There was a good sort of philosophy of care versus other wards which were not so popular. So context can vary, and we have an intuitive experience of that, I think, as healthcare professionals, that it's important to use when you're thinking about what is the logical unit of analysis, or what are the boundaries of my case here. So it's not about random sampling, it's about purposive sampling. And there are a number of different ways which you can sample your cases, but generally they do involve a purposive decision. You don't just take a convenient sample or a random sample as you would in other types of design. And there's two ways or several ways in which you can design the sampling of case sites. You can go for exemplar cases or atypical cases that are known to be being good at something. They're shining stars, because you're going to get rich information about what's made something work in that setting. Why is this so successful? Just thinking back to my own PhD, so my own PhD I also used case study design there, and I was interested in, at the time there was a big push for nurses to be promoting health and preventing ill health, as well as looking after people who are already sick. It sounds quite familiar. We're coming back to it now, I think, in healthcare policy in England, in the UK at the moment anyway. So I took individual wards as case studies, and actually used multiple methods within each ward to understand how or if nurses were enacting this more kind of preventative participation in care element. And as part of that, I knew of some wards in a particular hospital, in a particular trust, that were, had established good reputation for that kind of patient participation in care philosophy. So deliberately sampled those to try and understand what was making that work there. But also, it's equally acceptable, and there are other advantages of sampling on the basis of typicality. Is this a typical A&E? Is this a typical ED in which paramedics might find themselves prescribing? And that's also easy to justify. So you think about typicality and generalizability in those instances. You've then got a choice to make of whether you're going to do a single case study, and for a PhD, because of the kind of rich, in-depth, often complex, multi-method design that case studies involve. You don't want to overstretch yourself. You might do a really good PhD on the basis of a single in-depth case study, or my student Adam is using just two. I think any more than that would certainly have stretched him. Or you can use a multiple case study design. So if you're looking for funding for studies, then you've got more resources, more time to actually maybe invest in doing case studies across several different sites. The advantages of which is that you can compare different contextual features in order to build theory. So yeah, I think I've said this already, really, but when you're selecting your case, at the design stage, you've got to think about where are those boundaries, which clarifies the nature of the case study, the time period covered by the case study, its scope, beginning and end, the relevant social group, organisation or geographical area of interest, the types of evidence to be collected within each case, and the priorities for data collection and analysis. So, that should be clear. We want to know what the boundaries of the case were. What are you going to collect data on? What's outside of your scope? And then just some practicalities about data collection and analysis. I mean, it's the same as, I suppose, if you're doing some ethnographic piece of work that was focused on understanding culture. Access is incredibly important, and you've got to have people who are willing to have you there over a prolonged period of time, willing to share information with you about the thing that you're interested in, and that might be at different stakeholder levels. You might want to interview, prescribing leads for the trust, as well as senior consultants. This is what Adam has done, as well as the paramedics that he, wanted to spend lots of time with. Hours of observation he's done in that setting, shadowing them, working with them, seeing patients. So you just can't do it without people wanting you there, and not only just wanting you there, but being having the time and the motivation to talk to you about the thing that you're interested in. So it goes without saying, really, that it does draw heavily on people's goodwill and about having you there. So you're also going to be thinking about multiple sources of evidence. Case studies are not really single data designs. So you might, in our, it's the ACT-Med study, the one I'm talking about, which was the end-of-life medicines. So what did we do? We interviewed, so we went to the GP site, and we interviewed any healthcare professional who was involved in the delivery of end-of-life care at that site. We recruited 10 patients within each site. We asked them to keep logs of their medicines access experience over time. We interviewed them as we recruited them at 4 weeks and 8 weeks into the study. We collected documents about each site that were relevant to access to medicines, and we looked at patient records, both to look at what medicines were being prescribed by whom over time, but also we had a health economist on the team. So within each case study, he was drawing on patient records about healthcare service use, unplanned admissions, admissions to hospice, use of emergency services, in order to understand the resource use within each case. So multiple sources of evidence are used. Prolonged engagement with the case. So if you're doing a PhD, not impossible, especially if you're doing it full time, but think about the resources that you will need to stay with that case over time. They're not quick. They're not something that should be done quickly, really. And then another key defining feature of data collection and analysis is this idea of triangulation. So it might be triangulation through different sources of data. So you might be triangulating your observation with your healthcare professional interviews and then your documentary analysis. You might also have some patient interviews in there. So different sources of data. I said that wrong, actually, sorry. Patients, healthcare professionals you might have, so different sources of data. Your methods, you might be triangulating observation with interview data, with documentary analysis, or this was the case with my the project that my PhD was embedded in. There was more than one of us collecting data, so we needed to triangulate our own perceptions and data collection methods across each other. So just thinking about writing up, this is tricky. Case studies are often defined by a lot of rich data, and it would probably be obvious from what I've said that might be, from different sources, different methods. So then you've got to come back to, how do I organise this and how do I write this up to both answer my research question and to clearly convey the context in which the phenomenon was sitting. So important when you're doing case study research that you might want to understand something about the history of the case, what's happened here before that's relevant to electronic prescribing or to paramedics suddenly being prescribing, what were the roles before, what was service delivery like before. History is usually important, and actually writing that up as part of the detail of the case. What happened to get to the point that you're interested in might be important. Day-to-day activities. So again, I talk about my PhD student. He is writing a lot about the A&E department. So what's the population it serves? What's the average daily throughput? What are the types of patients? What are the services that the A&E offer? What's the staffing like? What are the physical facilities in what does that look like? All of that is relevant to what he's trying to understand. Paramedic prescribing within a very busy A&E department. So again, it's part of describing the context, I think, really, the history, the chronology, day-to-day activities, describing the case. And this all kind of relates to the point I made earlier about external validity. People need to read your case study and think, oh yeah, I recognise that. That's very similar to the A&E in my trust. So therefore, it's very likely that the findings from this study are going to be relevant to the A&E in my trust. So it needs to be thick, rich description, and you need to be collecting data on that as you go through, obviously, about the staffing mix, the numbers of patients. Adam's got data on what's been prescribed over the last year by both paramedics and other healthcare professionals, the number of controlled drugs that have been prescribed. So in the end of the day, you might not need it all, but collecting it as you go along to describe the case and the context, I think is really important. Then you've got to do the analytic bit, and you've got to crunch through your data from different sources, remembering what are the key issues for you, or themes for understanding the complexity of the case. That is a very shorthand way of talking about how you write up. But it draws on the principles of qualitative analysis and triangulation, really. It's about description. It's that description of the case that I talked about, but it's got to move obviously beyond description to some kind of analytical themes, and then you're going to be making assertions about links between the context and the themes or the findings. I've talked about this, but it's about, we know from other types of qualitative research that thick, rich description aids transferability, that people can recognize the context or not and think, no, this is too different. It wouldn't work wouldn't apply to my trust or my patient group or my population. You've also got the issue of I always say you should analyze, if you've got multiple cases, even if it's only two, you analyze within your case first, so you really understand through triangulation, through your analytic process, through your theory building or your links between themes and context. You understand what's happening in that context first. What are the things about that context that shape the thing you're interested in? So you do that for each case that you've got, and then you would go to your cross-case comparison in order to help you further build theory or explanation. So where you've got differences between cases, so I go back to my own PhD for this. So actually I had 6 wards that were case studies, and thinking about to what extent nurses were able to promote, new concepts then, like participation in care, more of a health promotion, preventative type approach. And I had some wards that were sitting at a sort of positive end of that spectrum, and some wards in my PhD that were less, the nurses were less engaged in doing those kind of activities. And through doing that comparison, it seemed to me that the wards that were better at it, where the nurses were better at it, actually the nurses had a lot of control themselves over the way that they worked. So there were things like how care was allocated, how it was organised, continuity of care. There were teams within the ward that staff nurses were responsible, and they would have control over when staff had breaks, or making sure that there was continuity of care. And it was, well, my theoretical explanation in the end, without going into too much detail, was that where nurses feel a certain degree of empowerment and power, they're able to engage patients in a more equal partnership with them. Where they're disempowered, where they've got no control over their work or very little, they're more likely to want to exert some kind of power and authority over patients, and there's more of a hierarchical approach. So I could do that by looking across those cases and seeing where the different contexts led to different outcomes. A very short explanation for the benefits of cross-case comparison. And then what you really got to do is this final stage of interpretation about generating meaning from looking at context and the thing that you're interested in. This is the last slide. So issues in case study research. So there have been, I don't know whether perhaps they're not quite so challenging now, but this kind of paradigmatic debates about, if you choose case study research, are you going to take a positivist approach or interpretivist? I think now we probably feel more comfortable with it depends on what you're interested in. It depends on your own philosophical or epistemological position, but as long as you justify that, I think maybe that paradigmatic debate has abated somewhat. This is a personal thing for me, but I think often when I'm reading research or looking at PhD students' research, you can do a non-case study piece of research and have different sites where you might just collect data. You might do interviews, you might do a survey with patients, but it definitely isn't a case study, because you're not interested in context. You're not doing this kind of multiple methods, triangulation approach to understanding context. So beware that there are people who call their sites, when they're just doing qualitative research, cases. But there is a difference between, as I hope I've made clear today, really engaging in case study research and just calling qualitative or even quantitative approaches to research cases or sites. And then I'm afraid this is still an issue. The last point here, thinking about case studies take a rap sometimes because as you can tell from what I said today, there are not going to be many of them in a, certainly not in a PhD, but often not in funded studies, because that's not the point. You want rich, in-depth data on context, and generalizability or transferability usually comes through, linking to theory. So it's theoretical generalizability. It's not statistical generalizability. You don't need to have lots of them in order to make your findings generalizable. It's more about the principle of transferability through rich description, and linking to theory will obviously enhance the generalizability the transferability of your findings. However, I put in a bid recently to NIHR, where we part of the design was to use case studies, and this was looking at deprescribing in general practice. And we made the case for doing ethnographic observation within each case. There are only a small number of cases. I think we said we'd do 3, looking at different contexts to see how deprescribing was going to work. And the feedback we got wasn't that wasn't enough. And how could we generalize from so few a number of cases? The problem is if you go bigger, you can do it. You need a lot more resources to do it, but you run the risk of your case studies being much thinner in data and not actually adequately explaining context. Or but there we are. So those issues of numbers and concern about numbers are still out there. Some key references for you, and some are older than others, but they're still, classic texts. And I would encourage you to have a look at, for those of you who are thinking about using case study research, a good paper last year came out, Triple C, I think it's Case, Context and Complexity. This is only in relation, this one, to complex interventions, but starts to pull out reporting principles for case study evaluations. And I think that's really important, because it starts to bring case study up as something that is a transparent, reproducible, reportable way of undertaking research. So that's me, and I'm very happy to take any questions from anybody. I think Parveen was going to, she's come back in.
Thank you so much. That's been really, really useful, and really I've learned a lot. And I thought there was quite a lot of similarities in terms of the approach and what we do in terms of the certain extent constructivist grounded theory sort of aspects, in terms of how the data is collected and how it helps build kind of an understanding of the processes of what's going on.
Yeah.
So
stop sharing. Yeah.
Yes, please. So
yes.
Over to questions. Any questions, any comments, please?
Anyone using case study or thinking about using it?
In the chat box, a department is big enough and trust would be mind-blowing. Yes, I think there would be too much information if you did it across the trust, isn't it?
Yeah.
Parveen, it's Jonathan here. I don't know how to raise my hands. That's why I've just spoken. I've not used Zoom before. So my name's Jonathan Elliott. I'm a consultant nurse at Manchester Royal Infirmary up in the Northwest. And I've just started doing a case study relating to an acute medical unit and the experiences of nurses caring for patients with acute mental illness, because it's becoming an increasing problem.
Interesting.
I just wanted to say thank you, because that was really good. And I have got one of my doctoral interim panels coming up, and what this session's done is reaffirmed I'm along the right track.
Excellent.
So all the names that you've used and the stuff that you've said has just given me a bit of confidence, because it looks like I'm bang on track. I suppose the one thing for me is making sure that the analysis process is right, and that the triangulation of data and the validity, really. I think for me, for my first piece of research as a doctoral student, it was identifying and trying to get my head around that power imbalance, and looking at Stake and Yin, in the fact that Stake very much talks about gaining meaning through the researcher's interpretation, and trying to sort of discuss and document in your findings how you've managed to manage that. I just wondered if you had any tips really for that, in relation to how you would manage the imbalance and also how you would convey that in your writing.
The imbalance in
The
terms
power imbalance. So as a researcher, I was the unit that I am conducting my research on. I used to be a senior nurse on several years ago.
okay.
So it's about, I'm going to be constructing the meaning through the various methods, through the various sources of data. It's discussing how my view and my lens will influence that, but how I'm making sure that I am using a reflexive way of making sure that's a positive thing, not a negative thing. And then also the other thing was about, because I used to work on there, about how I make sure I'm not influencing what's being said or given. Do you know what I mean?
Yeah, I do. So I think, and the PhD student I'm talking about has also got some similar issues in one of the settings. So I think it's about building checks in as you go through, isn't it? It's about being reflexive. It's about keeping those reflective notes. I don't know what methods you're using, but Adam is, he's doing this kind of ethnographic observation. So he keeps reflexive notes about, his own preconceptions and maybe where those have changed or how they might be influencing what he's doing. So that's ongoing as data collection. He's checking in with me and his other supervisor. I mean, I'm not a paramedic, I'm a nurse. His other supervisor is a medical sociologist. So we ask him obvious, naive questions, which kind of blow away his paramedic lens a bit, I think, really. So it's about documenting that you've checked in with your supervisors, isn't it? It's also about all the things that we should all be doing with good qualitative research. It's about, making your audit trail transparent about why you sampled particular things, observations, patients. It's about making your data analysis trail obvious, isn't it? So that people can see that you followed accepted principles and there's a transparency about your analysis and write-up, that you won't remove yourself completely, but you have followed accepted principles. And I think that's not anything more complicated than that, really.
That's lovely. Thank you.
Yeah.
Thank you very much.
I'm sure you're onto it, but
Yes,
that's
yeah.
really interesting. Yeah.
Thank you.
Yeah. And
I think
also,
what I usually also suggest is having some sort of reflection as to who you are, because what it allows you is that once you've written as to who you are and why you're interested into the topic, and so I thread through reflection at each stage. So at the time of introduction, when you're developing research questions, so once you've written it down, you understand where you're coming from and what would be your influence on the, and if do you have any kind of thoughts or biases or your views, particular views about something. So then that sense keeps you kind of gives you a reminder to have a look at those things as you progress. And as Sue was saying, reflecting on when you're transcribing, when you're analyzing, I usually ask my students to write small little reflective notes as to what did you think? Did it challenge you? So then those notes become your data in itself as well later on. And they allow you to write a very good reflection at the end. And so you yourself are very clear as to how it has changed you, how you have affected the study, and how the study has affected you as well.
And then interweave that into your writing. Yeah.
Yeah.
Because what I've done is I've framed myself and my position and my experience, and then I've been writing reflexive notes. But it was this thing of, do you do that separately? Do you interweave it into the text and the discussion? Do you do it at the end in the appendix? But I've done it like you've mentioned. So that's been really useful. Thank you. Thank you very much.
And also not to forget that, you'll also have some benefits of bringing those
Yes.
So it's not all bad.
No. Okay. Thank you.
Yeah. Excellent. Oh, that's useful. Any other questions? Any other comments, anyone? Hi,
Yes.
Joanna.
Hi, could I ask a question? My question's around methods of analysis, really. I've got 4 different data sets. So I've got surveys, focus groups. I did a survey, and I've also analysed documents as well. So obviously I've used different ways of analysing those different data sets. And it's how I sort of sew those together and and evidence why I've chosen those particular methods to look at those sort of data sets bring to the case. Have you got any sort of direction for me on what I should be considering in that? 'Cause they are quite different. So I've used like reflective thematic analysis for my focus groups and my interviews, but that's not quite so appropriate for the survey results and the documentation.
Yeah, no, I think you go with the method that is right for the single method. So you've obviously done mixed methods case studies, haven't you? So which is,
Yeah.
I didn't talk about that, but that's also a thing, but which is great. So mixed method case studies. So you could draw on the mixed methods literature to think about how you actually bring those findings together in a, people talk about sequential or concurrent, or so I'm sure you probably looked at that, but definitely go for the method that suits the particular. And you might have, well, you will do your analysis of single data sets first, and you'll have a choice about, you know, in your write-up of the case, do you present all those single methods first? So you present the results of the online survey, then the thematic analysis of focus groups, and then do you do some kind of integration of, okay, having done a process of triangulation, I can see that there's similarity through the data sets on this particular question. That's where the creative bit comes in, I think, and where you have to, you know, jump off and think with your supervisors, if it's a PhD, how do I best now present the themes that are coming through? I think I'd be inclined to analyse each single data set and present those, and then present the integrated picture with some attention to the context, the data that you've collected about the context of the case.
Yeah, I think it is a PhD I'm doing. I think I'd sort of got too weighed down in using one method and realised that it really didn't work. It didn't sort of, it didn't present the voice from each data set. So
yeah,
so I've sort of gone back to it and reanalyzed it using different methods. So it's that input.
definitely.
Yeah.
You'll have to use different methods depending on what your data source is, and you know, and then integrate it later on. Maybe not looking at completely only similarities, but how do they
Indeed.
sort of build on each other,
Mhm.
and what sort of information is missing in one aspect, but it gives or is limited, and the other data set gives more sort of understanding or more sort of insight into the issue, and that's what is going to make it more interesting. And then, of course, your own interpretation of, like, you know, what did you think and how all that is developing.
And also, the differences between different data sets and different data sources is also important. You know, patients think one thing and talk about experiencing one thing, but healthcare professionals talk about another. That's also important, isn't it? So yeah.
Thank you. Thanks.
Thank you. Thank you so much, everybody. And thank you so much, Sue, for doing this. That's been excellent. And I'm really glad that it has been useful. So we've got 2 PhD students who would find this really useful in terms of kind of understanding. Sometimes it's important to listen from somebody else, and then that gives you either that sense of comfort that what you're doing is not off the plot completely, or helps you understand and think of few more questions that you want to know. And we usually do not really get these sorts of sessions. And for me, it gives me sort of that content that it has been useful. We usually talk about quite abstract stuff. And this kind of thing you only read either in books or very often limited lectures. So that has been really very, very useful. And I hope you all have liked it. So thank you again. Our next session would be in December. And that is also a methodological one. So I hope people are going to find that useful too. And do check out for that session. And yeah, thank you so much. Thanks a lot, Sue, for taking your time and doing this interesting session as well. Thanks.
My pleasure. Thank you, Parveen.
Thank you,
you,
Sue.
everybody.
Thank you,
Bye.
Parveen. Bye-bye.